Welcome to the Everything Epigenetics podcast, where we discuss DNA regulation and the insights it can tell you about your health. I'm Hannah Went, and I'm the founder of Everything Epigenetics. Today, my guest is Dr. Meesha Dogan. Meesha is actually the CEO and founder and director of Diagnostics. Diagnostics is an AI-driven precision cardiovascular medicine company based in Chicago. This conversation is really important to me. We dive into how heart disease is just such a major concern for so many people and how epigenetics plays a role in determining our risk for heart disease and the connection people should be aware of. My father passed away at a super young age when I was 13 unexpectedly from a heart attack. So I'm just personally so interested in how epigenetics can really help us move the cardiovascular field forward. We talk about the role of AI in modern medicine and how AI actually helps identify these epigenetic biomarkers for heart disease that Meesha's looking at, and how we can really use this machine learning to pinpoint risk before traditional methods can even find risk for heart disease or heart disease itself. We also talk about the difference really between the Clearly test or traditional methods, which may give you heart disease risk compared to diagnostics. We dive a little bit into more of their test. Meesha gives a really cool real life example of how this testing can play out practically and actually start to change people's behaviors over time and give specific interventional treatment plans and strategies through the reporting itself. We know epigenetics has been used to understand the effectiveness of treatments for heart disease and even help people reduce heart disease through the cardiodiagnostic testing. We end with what she's most excited about in the next 5 to 10 years, which I'm not going to tell you. You have to wait until the end to listen, in terms of epigenetic research. Now, a little bit of an introduction into my guests. Meesha, over the last 13 years, has really bridged her work in AI, epigenetics, and genetics with building, commercializing, and scaling next-generation DNA-based cardiovascular tests that can be deployed across the world to better prevent, detect, and manage cardiovascular disease. She's been leading this company since 2017. They hit a massive milestone in 22 where they hit the NASDAQ listing for the company itself. Meesha holds a PhD in biomedical engineering and an MS and BSc degree in chemical engineering from the University of Iowa. She is a leader and an innovative visionary in this field to really make heart disease prevention, detection, and management more accessible, personalized, and precise. She is deeply involved with the company and stems from 2 generations of heart disease in her own family. She's married to her college sweetheart and resides in Chicago with their 2 dogs, Sophie and Teddy. Now for my guest, Dr. Meesha Dogan. Welcome to the Everything Epigenetics. Meesha, I'm excited to chat with you today.
Well, thank you for having me, Hannah.
Of course. We're going to hop right into it. I have a lot of questions. I'm super curious, especially about your company, Diagnostics, that we'll get into later on. I first just want to learn a little bit more about you. What first sparked your interest in epigenetics and personalized health? Mm-hmm. You're one of the very few epigenetic companies out there. Yes. In particular, maybe to make that question a little bit more targeted, was there a specific moment or, it could be an aha moment or maybe just a bunch of moments that came together, some type of discovery that made you realize this was the field for you. This is what you really were made for.
I would say that it was love at first sight with epigenetics. Certainly infatuation at first because it was a brand new field I came about back in about 2008. So I've been in the world of epigenetics now for over 16 years, which just blows my mind because the field has come really far. And then I think there were a few different progressions that happened over time that really grew my love for the field of epigenetics. And a few of those I'd love to share. First, it's of course, as I shared, I came across the world of epigenetics in 2008. It was brand new to me. I've only learned about about genetics. And when I heard about epigenetics, I'm like, what is this new world? It sounds so similar to genetics. Is it just a variation of genetics? And when I came to learn about it, what I think caught most of my attention was around the fact that it has to do with our lifestyle and environment. And I come from a family, and I know our company name gives it away, but I come from a family with 2 generations of heart disease, and that was always an interest. And to learn that it's largely lifestyle and environment, epigenetics became more front and center for me. That's really what I actually did my doctoral work in. But the other layer that I got to add was the world of artificial intelligence, which grew my love for epigenetics because now I was getting to learn more about it, look at different patterns, and it was such an exciting time. And that was around in 2010, 2011. And so I would say these progressions has really grown my love for epigenetics. And I think we're still just starting, barely scratching the surface. So I'm sure it'll be a long-term love with this field.
Mm-hmm. Yeah, that's great. You mentioned you've been in the field for about 16 years,
Mm-hmm.
and I've only been in the field for like a little, I think just about 5 years, because we started True Diagnostic, ran our first sample in July of 2020, but really started the idea of it, 6-9 months prior to that. So it's so interesting. I've seen all of these different areas of epigenetics in particular, whether it's epigenetics as it relates to, the heart, like the work you do, or the brain, liver, lungs, etc., really explode in each individual area. So I couldn't imagine the changes you've seen across the field already, because I feel like I've seen enough, a lot already, but I'm excited for what's to come. And then interesting that you also have that, connection to heart disease as well. You said it goes back 2 generations in your family. I know to some extent it also runs in my family. I mean, it's, I think, the number one killer, or one of the number one killers in the US, right? My father passed away at such a young age, unexpectedly, from a cardiac arrhythmia, right? And that's obviously my parental side. And then on my maternal side, my uncle passed away unexpectedly, from a cardiac related event. So, I mean, that's not unusual to hear about those stories, right? I think everyone can relate in some way, which is also why I was like super excited to talk to you. And what really leads me into my next question, which is heart disease is everywhere. It's such a major concern for so many people. So I want to stick on this theme, of course, of my podcast, Everything Epigenetics, and really talk more about how epigenetic plays a role in determining our risk for heart disease. Are there really clear connections there that people should be aware of? Or, I mean, I know we're still getting into this research. I think just explaining that connection between the two first would be great.
Absolutely. The thing about heart disease that sometimes I find a little hard to wrap my mind around is how complacent we've gotten as a society, right? To your point, a lot of us know someone directly or indirectly affected by it, yet, we feel and think of it as just something part of life, something part of, society and our norm, when it doesn't have to be the case. Now, in the case of heart disease, the reason why epigenetics becomes really powerful is if we take a step back and we had to dissect heart disease, about 20% of it is genetics. So when we talk about family history, a lot of times we're talking about genetics. But if you paused, a lot of people would realize is the way you eat, the way you grew up, your certain environment and lifestyle, that's also family history. So genetics alone is not your family history. But the reason I emphasize lifestyle and environment is really because that's what epigenetics captures. It captures what we're doing in our day-to-day lives, whether it's a certain behavior, what we're eating, what's happening around us that we're part of. How is that affecting this specific DNA biomarker that is dynamic in nature? And that's critical for heart disease because 80% of heart disease is non-genetic and largely comes from our lifestyle and environment. So as a result, you can really see how looking at an individual's person's epigenetics could really hold a lot of insights into the impact of what they're doing and the impact of their environment and the impact of their behavior. But I think the other aspect that really excites me about epigenetics and in the context of heart disease is there are insights in there. As much as it's pointing out a problem, there are insights as to where the problem is coming from. And that is very powerful because we're not just pinpointing a problem, but inherently built into that information is some level of solution. And I would argue a large window into the solution. And so therefore, with epigenetics and even at cardio, and to take a step back, cardio was actually a direct line from my work many years in epigenetics on artificial intelligence. And it was actually my doctoral dissertation. So I spent a lot of time on the research side, being able to say that not all epigenetic biomarkers are relevant to heart disease, just like how not all epigenetic biomarkers are relevant to cancer. And how do we identify those specific ones and the patterns of these biomarkers in a way that can be meaningful to proactively identify those at risk, those who have undiagnosed? Because to your point, many people, it's sudden. Right? The sudden onset of heart disease, a lot of people who have heart attacks or strokes don't necessarily have traditional risk factors of some level of education. And epigenetics, going back, I tend to call it the source of truth, right? You're going to the source of the information, which is the molecular level, which is what's unique to each of us, which is our DNA. And we're going to the source of it to understand what's going on. So truly, epigenetics is capable of identifying and providing that information, but more importantly, have insights into the solutions.
Yeah, I think that's so important, right? Why test if you can't do anything about it? Right? I hear that. I work with healthcare providers day in and day out, and they want to make sure that they have the how, the why, the solutions to be able to affect that actual change. So it just becomes really difficult when you report out an increased risk or even a decreased risk, because you probably want to further decrease that said risk if you're not giving direction on how to do that, or, you know, supplying them with some more information. That way they can at least make a decision for the patient in terms of an interventional treatment plan or strategy. So my head goes to then, Meesha, the how, too, and in terms of the laboratory side of things, right? You mentioned you were really heavily involved in the research. This is what you did your dissertation in. I'm used to running samples from a blood spot card on an array bead chip technology. We usually talk on the podcast a lot about those aging algorithms as it relates to epigenetics. So, you know, combining particular CPG locations to then predict that outcome. So what are you all doing on the laboratory side? Walk me through this. What type of sample is it? What are kind of the steps? And you can definitely make it a little bit more from like a 30,000 foot view too.
Yeah. So we're using blood sample. And I think blood-based testing, I usually say it's, other than you standing on a weighing scale or using a blood pressure cuff, it's probably the easiest to deploy. And one that you can think about when it comes to scale, because accessibility is key to prevention. Accessibility is key to better clinical management for patients. And so for me, it being a blood sample is absolutely wonderful. Now, when we do the development side, we actually have 2 clinical tests on the market. But when we do the development side, we do use genome-wide information. And our test does couple genetics and epigenetics. So we're using genome-wide information as the starting point. And that's really where artificial intelligence comes in, because we're using it to recognize the patterns, because we don't need to measure 10,000 locations if they're not robust and relevant and they're not providing the level of information or the type of information you need. Similarly, the biomarkers that would be relevant to coronary heart disease would look different than something for stroke, just because we know even though there may be some overlap in pathophysiology, it's not necessarily identical. And so for us, that's where artificial intelligence comes in. But fast forwarding, once we have the product, it's a panel of these biomarkers, and we're using the machine learning algorithm for interpretation. But on the lab side, what we actually do is, genotyping is easy. It's dime a dozen. You can get TACMAN assays. They're so readily available. With methylation, which is the specific epigenetic marker we use, it's not off the shelf where we're able to, just buy something and deploy it. So we actually do custom development of our DNA methylation assays in a way where we use digital PCR specifically to develop those assays and deploy them. And the reason for that is because we've shown, and many studies as well have shown, that the precision of measurement using a technology like digital PCR is very high. And the preparation to get a sample for digital PCR is also simpler than trying to do something like an array. So it's almost like the KISS principle. We want to get to the information, but we want to keep it simple and robust and reproducible. And digital PCR is another cutting edge technology, right? It's been around, but for DNA methylation, it's just relatively new. We've seen more and more companies come out with instruments for it. But that's another area that we pride ourselves in being cutting edge.
Yep. No, that makes sense. So is it just a blood spot card, or are they larger? Do you have to go get your blood drawn?
So two modes. It is larger than a blood spot. So it's either a finger stick into a standard lavender top, or it's a full venous draw, one or the other. And the reason we wanted to do that is, again, accessibility and what, agility we can build into our products, and how can we increase the mode of collection.
Mm-hmm. Great. No, that makes sense. Just wanted to be clear there. Mm-hmm. I'm sure those listening as well are also curious. Now, all right, I'm walking through this process in my head, right? You get this kit, you want to understand your risk from an epigenetic standpoint as it relates to heart disease, and you take the sample, you send it in. You said you measure positions on the genome first, right? So let's walk through that. Does AI have a role in that area, right? Are you looking at particular positions? And then when do you send it off, or when does it then go to the epigenomics step?
Yeah. So our tests are clinical tests. So they have to be ordered by a clinician.
Okay.
And so the prescription part can be done in person, or we do have a telemedicine partner. So there's an opportunity to do our tests fully remotely if you're using telemedicine and at-home sampling. But to your point, once it's ordered and once the sample is collected, the sample goes to the lab. Now, AI happens in the development phase. So in the development phase, we use AI pretty extensively. We have a whole engine that essentially takes millions and billions of data points across thousands of individuals, and we're identifying that pattern of genetic and epigenetic biomarkers that we're then translating and validating into those assays that we use in the lab. So in the implementation side, once the sample gets to the lab, we actually bifurcate the sample. So in parallel, one aliquot of the sample goes into genotyping for the genetic markers, and one aliquot goes into bisulfite conversion and then digital PCR for methylation assessments. And then the raw data that comes out, once it goes through quality control, goes through the final machine learning model that we had in the development phase. So essentially that pattern recognition now in the form of a predictive model. And then depending on our test, our risk assessment test provides a risk estimate of a heart attack event occurring in the next 3 years. Our detection test aids in diagnosing coronary heart disease. So it says whether or not a signal associated with coronary heart disease was detected. And those outputs come from the machine learning models.
Got it. From the machine learning and the AI, from that large data generation at the end. So yeah, it's really interesting you're combining both of them. I definitely think you need both. Now, are we looking at a future where the machine learning, the AI models, everything you're putting together for the interpretation of this large data, are going to pinpoint risk before traditional methods can. How does it line up against traditional methods? And, even if you want to give maybe an overview of traditional methods for detection to the listeners as well, that'd be great.
Yeah. And I think the specific example I'll go to is something called ANOCA, which is ischemia with no obstructive coronary arteries. And, traditionally, when we're thinking about coronary heart disease, we think about obstruction and we think about lack of blood flow, which is what happens when someone has a heart attack, is lack of blood flow and oxygen. And what we've learned over the years is in the case of ANOCA, about 60% of women who are presenting with coronary heart disease do not have significant obstruction. So traditional methods, for instance, that rely on obstruction as a way to diagnose coronary heart disease now becomes problematic. There is a gap there.
Yeah, kind of irrelevant too, right? There's nothing there. It's a poor test. What does it tell you, right? Sorry to interrupt and cut in, but I think that's an important point.
Yeah. And that's critical because, I still go through literature on ANOCA, and it just baffles me that there are studies after studies showing that when women used to go in or call the ambulance because they were having significant symptoms, even sometimes like strong chest pain, they were told that they were having acid reflux. Some were referred to a psychiatrist. And it's because we had a very rigid view on something like coronary heart disease. We did not acknowledge until I would say very recently that women have different signs and symptoms when it comes to these conditions. And we were trying to get the one size fits all going, where we're looking for obstruction, we're looking for obstruction, we're looking for obstruction. So I think that is one very clear opportunity, in addition to more traditional presentation for these conditions, where epigenetics would be and is very valuable. Now, the other part, going back to our point about earlier on not just pinpointing problem, but pinpointing some level of solution. I get the opportunity to talk and work with a lot of cardiologists. And a lot of times, one of the things they would openly share with me is certain technologies that we use today, especially the ones that are just looking at obstruction, lack the information of what do I do. I've pinpointed a problem. We know that stents are not for everyone. So just because we have an obstruction, a stent is not the answer. But how do we think about treating this patient in a personalized manner and not resort to the one size fits all? And I think that's another area that epigenetics has so much value beyond the traditional methods we use today.
Mm-hmm. Absolutely. No, it's super interesting. Just the ability for AI, machine learning to look through all of this data and start to make correlations and connections that we were maybe unaware of previously. So I'm super excited to see in the future how AI and epigenetic-based diagnostics are going to become a lot more prevalent, I think, especially in heart disease as well. Mm-hmm. Now, one thing that comes to mind and literally just did when you were talking about maybe more traditional ways people are maybe looking at some of these risk factors. I know maybe some more new innovative ways that people are looking at risk factors for heart disease. A lot of my providers that I speak with are going to use the Clearly, that whole heart technology. And for those listening, if you're not familiar, this is a company that's redefining cardiovascular care. Essentially, they leverage some new technology. They help providers better identify at-risk patients. They kind of do a entire scan of the heart. Meesha, I'm sure you can explain it a little bit better as well. But I would love to know if you all have any data from, Clearly scans at the same time of your tests, and if, or maybe you all are already working together. I'd love to hear your thoughts there.
Yeah, so Clearly focuses on using CCTAs as the basis and input to their algorithm. I would say the Clearly scans are based on anatomical presentation of heart disease. And we're in the world of looking at molecular presentation of heart disease. So very much complementary for the reasons that I shared. But one of the, I think, distinct feedbacks, and this is mainly for CCTA, not necessarily clearly, they're more on the software side, but CCTA does require exposure to radiation. And one of the other things that when talking to clinicians is epigenetics is dynamic. And you know this well, right? When you change your lifestyle, when you change your behavior, sure, it gave you and pinpointed where the solution can come from. But when you retest someone, you can get a window into the effectiveness of that treatment, which we ourselves have shown that you can effectively measure that in as little as 90 days. And now you can take a blood sample every day for all that matters, right? We're not going to be doing that, but for all that matters, that can happen. And there is no radiation or kidney failure or any kind of side effects related to that aspect. So it's like our technologies are very complementary to things like CCTA, but they look at a different, element of heart disease. It does capture those patients regardless of they have obstruction or not.
Got it. Yeah, I think to your point too, we already hinted on this a little bit, but it's the accessibility part, right?
Yeah.
As well. These clearing scans are going to be accessible. Again, radiation, I think, is a big point as well. So something to definitely be aware of, where you have the finger prick, into the tube, or you're going and you're getting blood drawn. It's going to be a lot easier. So, we mentioned your company a couple times. We're saying, cardio, or, formerly cardio diagnostics. So I'd love to hear even just a little bit more from you about the company. I know it's, come up for me several times. And, you all are really looking to alter the global trajectory of CVD. You're talking about this massive paradigm shift that we really need to realize. And there's a lot of innovation across the company and what you all are doing, whether it's risk assessment, risk management, earlier diagnosis, medical and lifestyle interventions, being able to do what we were just talking about, which is following up and evaluating those interventions as well, and then continuous monitoring, because again, it's one of the number one killers, and something we need to be aware of, especially if we have a predisposition to that already. So give us a little bit of an introduction to the company.
Oh, you did a great job.
I'm reading some stuff off the website, I have to say, at the same time, but wanted to cover it all. I mean, you all are really doing everything, I think, from, again, when the patient walks in the door all the way to monitoring and everything in between.
Yeah. And I mean, truly that is possible because of epigenetics. So Cardio, we were founded in 2017. And really it came from the years of our work in epigenetics. And I think the promise of epigenetics, it's not just its cutting edge science. It's not just it's a new paradigm shift, but it truly does help address the gaps that we have in clinical cardiovascular medicine. And some of those you touched upon. I mean, a lot of times we're looking at heart disease as almost cross-section when it is dynamic in nature, right? As human beings, when we are born, which is why a lot of times if people bring up genetic tests, I'm like, if I could do a genetic test when I was born and already know it's going to have heart disease, coronary heart disease, or stroke, then we already have the answer. But it's largely lifestyle and environment driven, which is why your risk for it and your personal heart health changes over time, for the better, for worse, right? It could go either direction. So for us, we saw an opportunity to address that cardiovascular care continuum. How do we use data-driven insights, a one-of-a-kind technology that, again, leverages epigenetics and artificial intelligence to really derive the kinds of insights that would be valuable across the cardiovascular care continuum for all of these different, both clinical and strategic decision-making stakeholders? And where we see ourselves is for anyone in any part of their heart health journey, whether you're early on looking to understand your risk, or you're later on where you may have signs and symptoms, there may be some suspicion where we need to detect heart disease. And then the management and monitoring naturally happens because of epigenetics, because they are sensitive to intervention, because they do provide information for personalized management. And so then we're able to not just, one-sided provide the information, but make it a feedback loop, because heart health is iterative. You'd get tested, your clinician will help you put together a management plan. You have to act on it. We know behavioral change is very hard for a lot of us. To give that time to come back and to understand how well you're doing, or even how effective these interventions are, whether it's your lifestyle or whether it's some level of treatment.
Yeah, absolutely. And I think there's a lot of things we can do on the lifestyle side as well to keep us heart healthy, right? You always see that on some foods, whether it's true or not. Sometimes that could be questionable. And I think it's always really helpful to hear more real world examples to see how this really plays out practically. So I'm thinking about, your healthcare providers who are using this test, recommendations, the why and the how that comes up on your report as well. Can you share any examples where epigenetics has been used to really understand the effectiveness of treatments for heart disease that may appear on your report? So maybe let's take an example where someone's risk came out high. What would we do to really help reduce heart disease risk? What would be really listed on their report? And you can even paint a picture of someone for us if it's easier, because I know this is super specific to the person. It's not just like a generalized answer where we can give you, restrict calories or eat healthier or go on more walks, right? So get specific as possible if you can too.
Sure. And I'll use our precision CHD test as an example, because I do have one specific example that's popping up that's top of mind for me. So we had one patient who took the test as a basis on the management side, on the basis to understand if there was some level of effectiveness on her treatment. And she was someone who unfortunately had had a heart attack and wanted to understand if all the medications she was taking, I think she lost like half or 3/4 of her body weight. She had done a lot of lifestyle changes, but she was also put on a lot of medications. But she's going through this motion without understanding whether they were working, or was she doing something for the sake of doing it without knowing that is she heading in the right direction to prevent something from reoccurring. And so she had seen the clinician and gotten our precision CHD test ordered. And she was also seeing a clinician, I think it was like every month or every other month. Instead, when she took the test, what the biomarkers showed is the treatments were very effective, that her epigenetic biomarkers were reverting. And they were starting to look like someone whose DNA biomarkers their epigenetic markers looked like they were a healthy individual. Not necessarily not because she's not healthy, but someone who did not have an event or someone who wasn't going through this level of intervention. And so she was able to talk to a clinician. They were going to keep on the course of what they were doing because they knew it was being effective. And they reduced the number of times that she had to go into the doctor's office. And she had confidence and the motivation, knowing that what she was doing was working, to want to continue and be on the right track, right? I talked about behavioral change. And for a lot of people, individuals, not just even clinicians, for the patients themselves, having that kind of feedback tends to be critical, tends to keep them motivated, tends to keep them compliant.
Yes. I mean, humans, we're stuck in our ways. No one wants to change their behavior, right? It's so hard to affect change. Some people are more resilient to that, depending on maybe how they were raised or their upbringing. But once you start to see on paper something like tangible, right? This is my risk. what I'm doing is actually having a positive, effect in your example you mentioned, or negative effect. And then it's going to actually change that behavior. So that's an awesome story. Thanks for sharing that. Hopefully many people can relate. Now, one thing I think is interesting, and I'm just personally interested in it, so selfishly I'm going to bring it up, are statins, right?
Yes.
Statins, these are really controversial in this space. Some people love them, some people hate them. They're a class of medications that help really lower cholesterol and help, or have been shown in some cases, to help prevent heart disease. They work by reducing the cholesterol your liver produces, helps your liver remove that cholesterol from your body, and then they may also reduce inflammation, and have inflammatory effects in your artery walls. So my grandfather was put on a statin. I'm not sure exactly why, like not because of the history. It's my dad's dad, not because of the history of heart disease or anything, but just because I think it was more related to cholesterol. He was actually like the 10% of people who get extreme muscle pain from statins. I mean, he still complains about it to this day to me, where he's off of the medication, has been off of it for years, and he still has achy muscles and joints, muscle tenderness, weakness, and I mean, it's affected his quality of life essentially for probably the rest of his life. I mean, he's in his mid-80s now. So, Meesha, what about your testing in statins?
Yeah, no, that's a great question. A lot of times, I don't think it's talked about as much as we should, that cholesterol does not equal heart disease. Hypertension does not equal heart disease. Obesity does not equal heart disease. They do elevate your risk, right? We don't want people to think that if you have those, then you should not be worried about your heart health. You absolutely should be worried about your heart health, but it doesn't also mean that you're doomed, right? So a lot of times, to your point, people were treated with statins on the cholesterol side as more of a preventative approach. Now, I will share that our Precision CHD test, the epigenetic marker, there's one specific marker in there. There are studies showing that taking statins do show a change in those biomarkers. Now, the one thing we're not in the practice of medicine. So we don't necessarily tell providers or patients what medication to take or not take. But I think what would be critical is for those who can't be, and by the way, the prevalence of those with muscle pain and issues is certainly much higher. I've met way too many people to say it's 1 in 100 or 10 in 100, right? It's just way more than that.
Yeah.
Which is again problematic, because how do you know what else you should be on? And how do you know if your heart health is being impacted because you had to get off of a medication that had massive side effects?
Well, I'll say too, real quickly, Meesha, before you go on, my grandpa doesn't know any better. If his doctor's going to recommend a statin, he's going to take the statin.
Take it.
Now he's on this whole health journey of taking like CoQ10. Well, if he's taking, something else that makes him deficient in CoQ10, why is he taking the, medication in the first place? And I mean, he's just going down, his entire health journey, which is great because he's becoming informed. But I'm just saying, most people are going to listen to their practitioners too.
They are. And I mean, practitioners are in the business of doing clinical care. But I've met practitioners who said, who have openly shared with us, I don't put my patients on statins for the sake of putting them on statins, right? Because that's the thought process and the clinical paradigm that we're used to. Statins is not an answer for everyone, because then that's us going back in the way we want to practice medicine from personalized to one size fits all, right? So there are certainly issues around the statin side of things. And we also know that just because you're on statins doesn't mean, people on statins don't have things like heart attacks. So I certainly think that's one area that is going to be, I don't want to say contested, but challenged more and more moving forward. But But again, statins, you do see changes in epigenetics when you take statins, and epigenetics the other way around could potentially inform whether or not someone should be on statins or how well the statin's working. Should they even be on it if it's not working, right? If it's not effective. I really think epigenetics can help with that.
Yeah. And you said your testing does include that? Or there's one marker?
It doesn't automatically include it. One of our biomarkers, studies have shown that it is affected by statin use. So you see changes in that biomarker as a result of statin.
Perfect. I know there are, a lot of spots that we're looking at, a lot of research out there as well. So I just want to make sure I heard you correctly. All right. So you gave a really awesome real world example of how this testing has played out and made a difference in someone's life. We got into the juicy world of statins. And now I do want to go back to just generalizing and playing the role of one size fits all. Meesha, if there were just 3 things you'd recommend for someone as more of a preventative approach to help reduce heart disease, like what are just the top 3 things people could do? And of course, maybe, sure, a lot of these are lifestyle related. Are there any that maybe people haven't heard of too? But happy to welcome the lifestyle recommendations as well.
Yeah. I would say number 1 is data is king, right? It's very hard. And I'll say this from myself, right? With such a busy schedule, are you doing enough? Are you not doing enough with your lifestyle? So getting insight into where you are as a baseline, I think first and foremost is very powerful. And I think it's powerful for the individual. It's powerful for their loved ones. It gives someone a sense of what can I do more? Or am I doing enough? Am I on the right trajectory? So the first thing I would tell anyone is get tested some way, shape, or form, get an idea and know where you stand. And then I would say follow up with small changes. It's very hard for us as human beings to want to make drastic changes. All of us want to. I would love to, right? I'd love to make these drastic changes. And so I think breaking it down into lifestyle and behavioral things that you can do bite size, I think it really does dovetail into good behaviors over time. And then the third thing I would say is remind those in your life that they should do the same, right? I think that's something that we could do more of. And that's something a lot of us in hindsight, when we hear about someone we know who had a heart attack. I just met someone who had reached out to me, and she said, I used to work out twice a day since my 20s, and I'm in my 50s, and I was having back pain, and I went to the doctor, and I ended up having 3 bypass surgeries out of left field. She didn't have any indication. But she said, my life's goal right now is to just turn around and remind others that your symptoms, no matter whether or not it is traditional, and I'm using air quotes for traditional, is something you should get checked. And she actually told me a story of her very good friend who had something very similar and said, I remember to just go in and see why I was having these symptoms, even though they're non-traditional. And she a friend ended up getting a stent. And so I think that's something we all could do, where we remind each other and people in our lives to take those steps, whether it's getting tested, whether it's making those small incremental lifestyle changes, or both.
Yeah, I love that. That's a great answer. Not what I was expecting. I was expecting like this list of things to do. And then you're like, oh, you're overwhelmed, and we're not doing number 2. You said making those small changes or habits. So you're right. Educate yourself, get the data. For example, I know my mom, and she has 2 sisters. They went and got like calcium scores, which again is not the end all be all, but maybe it's a little bit of a start, and they're getting interested. When my uncle, their brother, passed away, making those small changes in habits, whether it's, lifestyle or if a supplement or medication is right for you when you speak to your provider. and then reminding people to do the same. And then we'll add in follow-up retests if you are doing something that's a little bit repetitive to measure those changes. So that's great. Now we're coming close. We're coming to the end here. What are you most excited about in the next 5 to 10 years as it relates to epigenetic research? It can be heart disease related. It doesn't have to be. Just what's your personal interest?
For me, I think that the natural progression is drug development. And I think that is one area. If we're barely scratching the surface of epigenetics, we're barely scratching the surface of epigenetic-based drugs. Whether it's using epigenetics in designing clinical trials, whether it's using epigenetics to actually build out drug targets, understand side effect profiles, those kinds of things. So just in the drug and the pharma world. But I think I would say I'm most excited about the epigenetic-based drugs.
Oh, interesting.
I think they're going to be, I think in the next 10 to 15 years, they are going to the number of drugs we're going to see using epigenetics is only going to increase tremendously, at least in pipeline. We know how long it takes to develop drugs. But I would say that's what I'm most excited about, because it is going to be very interesting to get that feedback. A lot of times when we did genetic-based drug, when we did things like pharmacogenomics, I always look at it as being more one-sided. Of course, you can use other metrics to measure effectiveness, but I think with epigenetics having that inherent dynamic aspect built into it, it's going to be very interesting.
Yeah, you're right, because you can retest and then find the changes. It's not unidirectional, it's bidirectional. So it'll be interesting, like how the study's set up, like what regulators are looking at, what checks the box. So there's a lot of unknowns there. Now I have to ask, are you working on that, or is that just something you're excited about?
So we do have a product called the Cardio Innovate 360, which uses our engine as a basis to partner with pharma companies to identify these drug targets. Because, one of the bigger challenges, and this is something I saw the natural progression of epigenetics, was the science is not straightforward, but then it started becoming a data problem. You have so many millions, billions of these biomarkers. Again, what's relevant, what makes sense. And so for us, it's the ability to use the platform and the framework and the technology that we've already built, but just for a different use case. So we are certainly continuing to be in that space. Of course, not as heavy as our own clinical products, and building up the adoption of them. But it's something that we continue to dabble in, and I have a feeling we will be dabbling more.
Got it. Yeah. So you have this platform. You're just kind of maybe offering this other service, this other way to do some big data analysis. So I'm excited to see where the drug discovery leads us, because there's definitely way more questions than answers.
Absolutely.
All right, Meesha, I ask every one of my guests at the end the silly question: if you could be any animal in the world, what would you be and why?
Gosh, I would be probably a dog.
Oh, what kind? You have to name a kind.
A cockapoo. I have 2 cockapoos at home. They are the sweetest, most loyal and loving and cuddly things. They get away with a lot. I think that's the main reason I said a dog, is because I want to get away with a lot. I want to be naughty and be able to get away with it because I'm cute.
Yeah. And they probably have the best lives, right? Just dogs do in general, when they have really great owners, really great homes. So that's a good one. I like that answer. What are their names?
There's Teddy and Sophie. Teddy is especially, I always say he has gears turning. He's always calculating. So if I had to be very specific, I want to be Teddy when I grow up.
Perfect. I love it. I love it. The more specific, the better. Well, I have, your company website, LinkedIn's, Instagram, Facebook, Twitter, X, all the socials. If anyone wants to connect with you, though, what is the best way to get connected and learn more?
Yeah, LinkedIn. I'm usually on LinkedIn every so often, and I would love to connect with like-minded people. It's always fun to continue to expand my tribe. So I'd love to meet others who are interested in this.
Awesome. We'll make sure we have all of that in the show notes. Well, thanks so much, Meesha. Thanks everyone else for listening and joining us at the Everything Epigenetics podcast. Remember, you have control over your epigenetics. So tune in next time to learn more. Thanks, Meesha.
Thanks so much, Hannah. This was amazing.